tells us which one is what. Suppose I forgot it is a breech presentation or it's a cephalic presentation. Which is this chamber, which is this chamber, I don't know. So I will look at this bright dot, and this bright dot tells me that this is the right ventricle because that's the modulator ventricle. Which one is this atrium? This is the right atrium or the left atrium, right atrium or the left ventricle, left atrium. So you see this bulge. The bulge is always towards the left atrium. So these important findings will give you an insight of what's going on, and you can see the ostium septum and secundum septum, and they will bulge on the left side, which gives us the impression that maybe this left atrium is slightly smaller and the right atrium, and that is why people sometimes overcall that the right atrium is slightly larger. They diagnose tricuspid regurgitation, foramen ovale is obliterated, and ductus venosus is seeing problems. Remember that when we divide this line right here from the interventricular septum, it is actually the same, but this bulge gives us a wrong impression that it is going on the other side. So the intraventricular septum is seen beautifully on this side, but you see it looks as if there is a break here. It's not a break, it's the physics. The physics says that the more perpendicular, the more parallel you are to that structure, you might not pick up the edges of that. That's why we need to see this structure on subcostal view. So it gives this impression of intraventricular septal defect, but it's not. And that's why apical four-chamber view will not be sufficient to make a diagnosis. So now you can see the trapping of the tricuspid and the mitral. I always say that these valves, the tricuspid, they clap like females clap. So they just do like this when they clap. आवाज़ ही नहीं निकलती clapping. But when the males they clap, they do it very strongly. So I always compare that when you see the mitral valve and the tricuspid valve, they close and open, they close and open the way the females will clap. So it's important to understand this structure. Now we move from four-chamber view, apical view to subcostal view. Why do we need that? So the uses of apical view will be overlapping with the apical view as well. Evaluate the heart position, evaluate the heart axis, evaluate the heart size, evaluate the four chambers. That's common with the apical view as well. But identify the modulator band, pulmonary artery veins entering into the left atrium, that's fine. And will identify the foramen flat ovale much better than the, and will evaluate the intraventricular septum much better than the apical view. The reason is physics, and we must know that factor very well. We use this for measuring the area of the ventricle size, because the costal view, subcostal view, gives a beautiful image, and the measurements are easy. Evaluate the heart wall contractility with the end goal is another indication for use of the subcostal view. So here is the subcostal view. The subcostal view is telling us that we are scanning the heart not from the apex but from the side. It's very simple. When the sound beam strikes the perpendicularity, the better the image you get. And we all know that the intraventricular septum is thick here and is thinnest most here, which we will discuss again when we talk about the membranous intraventricular septal defect. This is what the line which I was talking of is much visualized better in this one. This is the tricuspid valve, the mitral valve. If I draw a line, the septum of this and the septum of this is below the line, this is going to be above the line, absolutely normal, which means a millimeter difference. If you concentrate on this, then very easy to diagnose abstinence when we talk at the end. So here is the RARLA, the intraventricular septum, and the subcostal view. Now we'll show you the 5-chamber view, which means you can see RA, RV, LV, RA, and you can even see a little bit of the aorta coming out in that sketch. Now this is what I meant by that when you take a subcostal view, there are some advantages. Number one, the intraventricular septum. Did I say that it is thick at the base of the apex and it gets thinner? So the thinner it gets, the more difficult to visualize in the apical view. And when you take the endmost, you can know about the contractility of the ventricles and the atrium separately, and can measure the size of the ventricles on M mode, or even if the calipers in your V mode, but your M mode gives you a better measurement than your V mode. So it's advisable that we must take the M mode. So here is the apical view, and in this apical view, you can see what I was talking about. It is thick at the base, it's thinner at this end, and if you were not in the subcostal view, you will never pick that up. And you can measure the ventricles much better in size and compare them with your measurements. So that's another apical view, which is just showing you the intraventricular septum, and you can measure them very nicely. I'm sorry I can't put it with my pointer on both sides, so I will stick on one side. So that's the subcostal view, to view your chambers and measure. Now we talk about the long axis view of the aorta, long axis view of the pulmonary artery. We talk about RVOT, LVOT, left ventricular outflow tract, right ventricular outflow tract. And in order to do that, how do we take the images? The uses of this long axis view is to evaluate the continuity of the anterior aortic groove to the intraventricular septum, evaluate the continuity of the posterior aortic groove to the anterior leaflet of the microvalve, evaluate the intraventricular septum for ventricular septal defect. These are the uses of the long axis view of the aorta. Evaluate the aortic valve above and below if Doppler angle is appropriate. Place pulse Doppler to evaluate arrhythmias, and place M-mode cursor through the right ventricle and the left atrium to evaluate the arrhythmias. That means you can crisscross the ventricle to atrium and see whether they are synchronized or not. If they are not synchronized, that means more detailed study and more views have to be taken, which we are going to talk of in a minute. The uses for long axis of the pulmonary artery is to evaluate the continuity of the pulmonary artery with the right ventricle. We know that from the right ventricle arises the pulmonary artery. We showed you the animation in the beginning. And the Doppler imaging of the pulmonary valve above and below has to be done in this case. Maximum velocity in the normal aorta is around 70, and the pulmonary is 60. This is actually plus minus 20, which means you can go up to 80, you can go up to 90, and if that is there, that means it's normal. Anything which is above 1, that means you are having very high velocities, and that can only be determined when you do the Doppler and PW in these areas. So here is the schematic diagram of a long axis of the aorta, which arises from the left ventricle. And the left ventricle will show that the blood goes into the aorta, and you will see some bright echo as you see between the aorta and the left ventricle, and that is the aortic valve. So seeing the aortic valve is very important, because some of the patients might be born without the valve in the pulmonary artery or the aortic, and that bright dot, you have to increase the master gain in order to see that aortic valve as well. So here is the picture. the same replica of, and then we talk, oh, I forgot to freeze, so I'll freeze at this point. So here is the same, the LV, which means the left ventricle, and left ventricle has a long axis view, and the aorta and the right jaw has a slit-like structure that is the aortic valve. So the presence of the aortic valve you must see and find out that whether it is normal or not. Then we have the pulmonary artery. The pulmonary artery arises from the right ventricle, and again the pulmonary artery will also have a valve, pulmonary valve. So if you focus on the right ventricle, you must see the gradual current of the pulmonary artery, and that's what we are going to show you in a minute. So this is what we talk about, the four views in cross section. You can see LV, RV, right atrium, the left atrium, and the aorta, and you can see the valve. Now if you draw a line right here, you will see the tricuspid and the mitral valve at that level. But now you are seeing the long axis view of the aorta in these dots. So here is a corresponding picture, the ventricles and the aorta, and you'll see in the line in our next scan. So here it is, long axis of the aorta. We can see the left ventricle, and left ventricle has got that left tubular structure arising from it, means the aorta, and right behind these two structures will be the left atrium, and these are the structures which you recognize in long axis of the aorta. So you will see a slit-like echogenic structure, an echogenic line in the center, means these are the valves are there, and that's the long axis view of the aorta. So we have talked about what are the importance of these long axis of the aorta, and that's how it would look like. Now we move on to, and that's the same, we move on to our next scan, and we can confirm this with the current doctor as well. Why it should be always blue? Because once the blood is pumped out of the left ventricle and goes into the aorta, it is always away from the pole, and that means it's going on. So any jet is produced, we'll talk about that in the abnormalities, but if you see blue color, that means it's normal, and once you see red, that means from the from the left atrium, the blood is going into the left atrium. That's the long axis view of the aorta, and you can see that right part of the valve. There you can see dotted holes, and that means the valve is there. And that's the long axis. So you have to scan this patient for a longer time in order to understand. This is the pulmonary artery, and that's the right ventricle. That's the right ventricle, and from right ventricle arises the pulmonary artery, and again you'll see the valve. And this wide opening is mentioned as that it is like a hockey sign. When Dr. Fazil was at Karachi, I was mentioning that aorta will curve like a hockey sign, the way we play hockey in Pakistan, and the other one is an open, and he said it's